Most people think dressing is simple, until you watch someone struggle with buttons, balance, or sequencing after an injury. Today, I'm breaking down the real OT approach to dressing, not just what it is, but what we actually analyze during treatment. This is a multi-step cognitive, motor, and sensory task, and every breakdown tells us something clinically important. OTs often evaluate issues like shoulder or hand strength, range of motion or coordination, impaired lower extremity function, poor activity tolerance, visual perceptual deficits, cognitive impairment, standing or sitting balance limitations. These are not just impairments. They're barriers to independence that guide your entire treatment plan. Dressing is one of the most underestimated ADLs, and one of the most transformational when patients regain it. But if you really want to sharpen your clinical reasoning, you need to master the difference between eating versus feeding, and most students get this wrong. Tap Part 2 to learn the difference and why it completely changes your documentation. If I gave you a checkoff sheet right now, could you clearly explain the difference between eating and feeding? Most clinicians can't, and it leads to inaccurate documentation and failed goals. Feeding includes setting up the meal, arranging and preparing food, bringing food or fluid from the plate to the mouth, using utensils or tableware, positioning yourself for feeding. Feeding is sometimes called self-feeding, but not everyone feeds themselves, which is exactly why we assess it. Eating includes all actions after food enters the mouth: chewing, manipulating food, moving it around the mouth, swallowing. Once the food is in the mouth, you're no longer feeding, you're eating. Two completely different skill sets. Imagine someone feeding you grapes while you relax on a beach. They are feeding, you are eating. This is always a favorite when teaching fieldwork students. Feeding impairments, arm weakness, poor coordination, limited endurance, visual perceptual deficits, cognitive impairment. OT interventions include restorabilities like strengthening, range of motion, cognitive, so perceptual training, motor control. Compensatory strategies like one-handed feeding techniques, energy conservation, step-by-step cues, task segmentation. Adaptive equipment such as a universal cuff, built-up handles, inner lip plate, adapted mugs and cups, weighted utensils, foam grips. Environmental modifications like adjusting table height, using contrasting plates, proper positioning, quiet eating environment. Or activity modification like change food consistency, retrain hand dominance, use finger foods, or have someone assist with the task. So now you understand eating versus feeding. But how do we actually turn these textbook skills into real-world rehab progress? Stay tuned for Part 3, where we pull everything together into functional mobility, caregiver training, and real-world treatment tips. Every OT has their textbook's cases. And then there are the cases that redefine what a challenge is. These aren't just physically demanding. They test our clinical reasoning, patience, and creativity. Today, we're dissecting the most complex real-world OT cases that push the boundaries of rehabilitation. First, the non-compliant or demoralized patient. A textbook diagnosis like a spinal cord injury is one thing, but treating a patient who refuses to engage or has severe depression is another. Our role shifts from occupational therapist to motivational coach, focusing not on strength gains, but on finding a single meaningful activity that sparks their will to participate. Next, the multi-system trauma patient, often found in TBI or extensive burn units. Here, we face a cascade of cognitive, sensory, and physical deficits simultaneously. Managing scar tissue mobility while addressing severe attention deficits and relearning basic self-care requires a constantly evolving, interdisciplinary treatment plan. It's clinical triage every single session. Finally, the environmental barrier. We can achieve perfect function in the clinic, only to find the patient's success evaporates at home due to an inaccessible bathroom, extreme poverty, or lack of family support. The challenge becomes advocating, resource finding, and modifying the environment itself, often outside of traditional therapy hours. These cases teach us that OT is not just about exercises. It's about solving human problems in complex systems. It's why we are unique. What was your most challenging case? Share it in the comments.